So our next session is a panel discussion of resources for individuals with intellectual and developmental disabilities, as we all know, IDD. So let me go ahead and introduce our panelists. First, let's welcome Haley Turner, who has 15 years of experience working with and for people with disabilities. Ms. Turner currently serves as the Associate Commissioner for the HHSC Intellectual and Developmental Disability Services, where she oversees the policy and program support for the 39 local IDD authorities. Haley, if you can just wave.
Good morning.
Next, we have Alex Cogan, is a manager of public policy and advocacy at the Arch of Texas, where she works to ensure that Texans with intellectual and developmental disabilities receive equal access to justice. Ms. Cogan worked to pass legislation in the 86th and 87th legislative sessions to further the state of Texas' duty to consider and support individuals with IDD. Ms. Cogan has also trained more than 850 criminal justice professionals, including peace officers, first responders, lawyers, and judges on interacting with and supporting people with IDD. Next, Alex, if you can also just wave.
Hi, good morning.
Kelly Land next is Kelly Land, who has worked in the IDD field with My Health, My Resources of Tarrant County since 2013. She is currently the program director for the Tarrant County START program, which helps people gain a higher quality of life by improving the delivery system for people with IDD and behavioral health needs. Ms. Land conducts trainings for local police and fire departments, school districts, hospitals, and colleges, and these strong partnerships continue to improve outcomes for people with IDD and first responders who interact with them. Ms. Land. And last, but certainly not least, we have Whitney Sherman, who is the Director of Autism, Behavior, and IDD Crisis Programs at the Andrews Center, where she oversees multiple behavior intervention programs that provide services to over 60 individuals of all ages. Ms. Sherman also provides trainings for families, teachers, and professionals in the community. She is currently pursuing a PhD in autism and neurodevelopmental disorders. Welcome, Ms. Sherman.
All right, we ready? Okay, good morning. Thank you for the nice introductions. Again, my name is Haley Turner, and I work with the Health and Human Services Commission. I'm glad to be here today. This is our second year with you, my second year with you, talking about resources and the service system for people with intellectual and developmental disabilities. We're really glad to be able to be with you. We appreciate the Judicial Commission on Mental Health for including IDD in these conversations. As you can tell by the introductions, this work is near and dear to all of our hearts and the things that we've committed our professional career to. So we're very pleased to be able to be in front of you and have these conversations with this group. I'm going to start off by giving some kind of high-level overviews of what IDD is, what the service system looks like, kind of from the 30,000-foot view, share with you some resources that we believe really are beneficial to people with IDD and most often with co-occurring mental health needs that may interact with the justice system. So after I give the high-level overview, I'm going to turn it over to my co-panelists because they're the ones that are doing the hard work out in the field, and they're going to share with you practical kind of how things work in their local communities and some of the really great programs that they run that are funded by the state and the successes that they've had around those programs. So first, I'm just going to start off with talking a little bit about what is IDD. And so I know that a lot of you, you may know this, and this may be just second nature to you, but for those of you that don't, we always just like to kind of talk through exactly what an intellectual disability and a developmental disability is and help you kind of understand the difference between that and mental health and where those two might intersect. So IDD is, or intellectual disability, it's a neurological condition, and it has significant limitations in intellectual functioning. So those are really the things that we're looking at when we're talking about an intellectual disability. So we're talking about intellectual quotient. We're talking about IQ scores. The ID is most often evident at birth or in the early childhood development years, and it has to have occurred before the age of 18. So someone has, some significant event in their life after the age of 18 that results in some impairments that wouldn't be categorized necessarily as an intellectual disability. And then we have the other pot of services and population population that we work with, which are folks with developmental disabilities. So that's a severe or chronic disability of an individual that is manifested before the age of 22. So we're talking about either they were born with it or something happened before the age of 22, and it's likely to continue indefinitely. So we think about, sometimes we think about things like traumatic brain injuries, things that happen before the age of 22 that end up impacting an individual and really having some substantial impacts and limitations on their functioning in things like language, self-care, mobility, self-direction, those sorts of things. So those are really the two kind of populations diagnostically that we're talking about today. And so when we start talking about resources for people with IDD, that's the population that we're talking about that would be eligible for the majority of these services. IDD is not the same thing as mental health or mental illness. And so we always just like to reiterate that those two things are distinctly different, but people do often have co-occurring IDD and a mental health need. And research shows us that around 35% of people with IDD also have a co-occurring mental health need. We've done some data runs at the state level in the past, and the numbers in Texas were much higher than that. But the research will show you across the population that it's about 35%. And where that becomes a challenge is that oftentimes the mental health needs of people with IDD are overlooked because a lot of times people will attribute it to their intellectual disability. So that's something that we call diagnostic overshadowing, and it really can cause difficulties when an individual is really having a mental health crisis, and people might think, oh, that's just related to their developmental status or their intellectual disability. They really might be experiencing depression, anxiety, or some of the other mental health needs that people experience. So it's really important to us to make sure that we intersect those two and that all of the services that we provide do a good job of making sure that those needs are met across populations. So now I'm just going to talk fairly quickly about what services are available for people with IDD in Texas, and then I'm going to turn it over to the other panelists to get into some details about how they implement those programs on the ground. So Texas has a wide continuum of services for people with IDD. We have everything from getting services in your own home, your family home, all the way to community-based group homes with 3 or 4 people living in them with a provider providing support, all the way to state-run larger institution-type settings like state-supported living centers. So there's a really wide continuum. Some of those services are in our Medicaid state plan, some are in Medicaid waivers, and others are funded through general revenue state funds at the local level. I would say that for purposes of working with you all, I would say that if you're working with someone who's needing a long-term services and support, what people most often are interested in is our home and community-based services waiver, which we call HCS, which tends to be the most popular thing that people that are coming through the front door are interested in. It's our most robust waiver, offers residential options. So if you're working with someone that may be needing some long-term support, specifically around residential support, that's something that that is often most highly valued by folks attempting to receive services. I'm going to talk a little bit about the local IDD authorities' role and then all the services that they provide to this population. So we talked about this a little bit last year if you attended, but the LIDA, the Local Intellectual and Developmental Disability Authority, is the front door into publicly funded services for people with IDD. So there's 39 around the state. They are the same entity as your local mental health or behavioral health authority, except in 2 parts of the state. So if you're familiar with your local mental health, behavioral health authority, you've probably got the same LIDA as the same entity. Where they vary is in San Antonio, where you have Center for Healthcare Services. The LIDA is Alamo Area Council on Governments. And then in North Texas, where you have North Texas Behavioral Health Authority, the LIDA is Dallas Metro Care. So other than those two, the other 37 around the state, the local authority is the same entity. So if you're looking for services and you have a connection with your LMHA, give them a call, and I'm sure they can get you over to the IDD side of their organization in good time. I'm going to talk about 4 kind of distinct services that the LIDAs provide that we think would be beneficial for you all to know about and to have access to when you're working with individuals who may be involved in the justice system and that have IDD. So the first one is crisis intervention services. So every local IDD authority employs at least 1 crisis intervention specialist, sometimes more. And one of our panelists is going to talk about the role and how they've operationalized that at the local level. Crisis intervention services are essentially real-time crisis response to people who have IDD. So you think about your MCOT teams, your mobile crisis outreach teams at the local mental health authorities. This IDD crisis intervention specialist is intended to enhance that support. So really working on maybe co-responding with MCOT when it's a crisis with a person with a mental health need and IDD, training our mental health workers on how to work with people with IDD, and working a lot with our partners in law enforcement and other parts of our professional system that may need some education or support in how to work with people with IDD. The crisis intervention specialists are also responsible for some follow-up on the TLITs matching. So I know we talked about this last year. You all had a lot of good insight into how the new TLITs matching for people with IDD was working. We are working on some enhancements to that, updating our probable match criteria. And at the local LIDA level, the crisis intervention specialist is a person that we've designated as the one to follow up when those matches occur. The next service that the LIDAs provide that would be of use, I think, to you all to know about is crisis respite services. So this is in-home and out-of-home crisis respite available at all 39 LIDAs across the state. In-home crisis respite means the LIDA is going to send somebody in. There's a crisis in the home, but it can be stabilized. So if it can be stabilized within 72 hours, they will go into the home, work with the system, work with the support system, try to get things leveled out. If that's not achievable, the LIDAs also have an obligation to provide out-of-home crisis respite. So there we're looking at pulling an individual maybe out of a natural environment, out of a group home, out of some situation that is causing difficulty in their life, getting them into a place where they can have some therapeutic intervention, get stabilized and get back. The intent of that obviously is to avoid people going into, more costly psychiatric hospitals, emergency departments, that sort of thing. And I know Kelly's going to talk a little bit about how they've operationalized their crisis respite at their local level. There's also one other service that I'd like to talk to you a little bit about that's new, and that is that we have 5 local IDD authorities around the state that have implemented outpatient mental health services for people with IDD. So this was funded last legislative session. Now, people with IDD can get their traditional psychiatric care through their LMHA or their LBHA, through a Medicaid psychiatrist, but we know with this population, it's not just as easy as going in, seeing a doc, getting a script, and staying on your medication. There's other things that have to kind of work with that system for folks to be successful. And so we piloted at 5 local IDD authorities around the state, at Bluebonnet Trails, Harris County, Austin Travis County, Tarrant, and Lakes Regional. They were the ones that received the award to pilot these services. And they include things like collaborative care case management, so that in between appointment time, working and making sure that folks are really getting what they need in between the mental health or psychiatric care that they're seeking. Skills training for the support system, for the paid providers, and really focusing on those mental health needs. We are looking to expand, if funding is available, we are looking to expand those services beyond those 5 local IDD authorities. So that's certainly something that I feel like is beneficial and has proven really good outcomes so far in the first 5 centers that we've piloted it in, and we're looking forward to continuing expansion of that. The last thing I'll mention very quickly, because I know I'm probably taking my minutes of time, is that there are also around the state 8 transition support teams. And so, I want to make sure that people know that these exist, because they could be of use in to professionals supporting people with IDD and mental health needs. And that's there are 8 transition support teams. They're housed at LIDAs around the state. So not every LIDA has one, but every LIDA has one that is designated to support them. So we have 8 around the state. They're regionalized. They cover all 39 local authorities, all 254 counties. And it's a group of clinical staff that are designed to support individuals with complex needs. So, they'll have a psychiatrist on their team, maybe a behavior analyst, nurses, other IDD or mental health professionals. And what they are charged with doing and what they receive funding to do is to provide training, education, and clinical consultation. And so that clinical consultation piece is what I really wanted to make sure that this group was aware of, is when you have someone with IDD and mental health needs that may be struggling in their community, or they're at risk of going into some institution, or maybe struggling with engagement with the judicial system, this transition support team and this clinical consult team could be of use in helping to really look at what's working and not working in that person's life, and offer some support to the individual's system, to their treating clinical professionals on things that maybe they could do better to kind of help the individual remain successful and stable in the community. I think that is it for me. So I'm going to turn it over to Alex at this point, and she's going to talk a little bit about what her agency is working on.
Great. Thank you so much, Haley. Good morning, everyone. So like she said, my name is Alex Cogan, and I work for the ARC of Texas. We are a statewide advocacy organization that promotes and protects the self-determination and human rights of Texans with intellectual and developmental disabilities, and I'm thrilled to be here with you today. So I'm going to talk about a project that we are working on. It's called the Whole Person Project. And we got this grant from the Texas Council for Developmental Disabilities. We're working on improving the supports provided to individuals with intellectual and developmental disabilities and mental health needs and their families by enhancing community-based mental health services and encouraging cross-collaboration training between IDD, mental health professionals, and anyone who may come in contact with individuals with IDD who are experiencing a crisis, such as law enforcement. So the second component of this project is to create lasting and effective systemic change. And this can look like a variety of things, including statewide policy and rule recommendations that will help eliminate barriers and service gaps that affect whether a person with an intellectual and developmental disability receives mental health care and the quality of the care that they receive. As you may have guessed, this takes a system-wide collaborative effort with stakeholders that represent a whole area of expertise, including community mental health and IDD providers, IDD advocates, and criminal legal professionals, as well as mental health experts. Before I go into the details of that project and the results from the research that we just completed, I do want to say that we feel very grateful to have this grant because the ARC of Texas is a grassroots organization. Simply put, that means that we get to work directly with individuals with intellectual and developmental disabilities, as well as their families, to hear what's happening on the ground in their day-to-day lives. We receive calls to our intake and referral line, and that gives us access to stories, experiences that they have from across the state. So we hear their lived experiences, we hear pleas to address challenges in the system, and all of this helps guide our policy and our advocacy work. All right, so back to that exciting project that we are working on. I want to go into a little detail about how we obtained the results that I'm here to share with you. We worked closely with the Center for START Services, which is based out of the University of New Hampshire, and we gathered community input about training needs and preferences of providers in Texas who serve people with intellectual and developmental disabilities and mental health needs. In order to obtain this research, we convened a group of stakeholders that included people with IDD, their families, IDD and mental health providers, Disability Rights Texas, local IDD and mental health authority staff, law enforcement, and lawyers. So we were really grateful to have a variety of individuals provide us with information about their experiences on the ground in trying to obtain services for individuals with intellectual and developmental disabilities with mental health needs. This group invited community members as well as their employees to complete a survey and to participate in a variety of focus groups and interviews. With this, a report was written, and I'm here to share some of the results with you today. I'm going to go over 4 findings that focus on training and collaboration efforts. The first one is crisis prevention and intervention, of course, right? We don't want to see people go through crisis. We want to get them at intercept 0. What we found is no surprise that there is unfortunately a lack of expertise in people who understand both IDD and mental health needs. As Haley alluded, this can be a really big barrier to effective crisis intervention and treatment, and we're hoping to solve that through a few recommendations. Some of the results from that survey include 93% of respondents who stated additional training and education was needed for crisis providers and response, and 95% of respondents said families could also really benefit from additional training and education in their role as caregiver, because we know that families tend to be that main provider of care for their loved ones. 95% reported that many law enforcement officers don't have access to the training necessary to recognize intellectual and developmental disabilities or the skills to de-escalate a situation that doesn't result in arrest, because of course we want to see people not enter the criminal legal system if we can. So, of course, there's that need for mental health and IDD training across the system as a whole to prevent and intervene in times of crisis, and the need to build capacity of the entire system of support, ranging from medical and mental health providers to law enforcement. The second focus was community mental health providers. There's a dearth of qualified staff, and this can often exacerbate reactive responses to mental health symptoms and increase demand for acute care. We know that experts exist in the state. We're very lucky about that. We are also a huge state, and a state that covers many different regions that have a diverse set of needs from urban to rural. So unfortunately, right now, the availability is not quite adequate to meet the demand. That includes waiting lists, lack of Medicaid providers, and community mental health services that tend to be largely limited to medication management. And one thing that I want to note and really hone in on is that there is this continued belief that people with intellectual and developmental disabilities would be unable to actively participate or benefit from therapy and mental health services. This is not true. And as Haley said earlier, mental health and an intellectual or developmental disability are different, but they overlap. Many people with IDD who've experienced a lot of trauma in their lives are experiencing far greater rates of mental health needs or challenges than the general population. So it's really important that we recognize that this population can benefit from therapy, can benefit from mental health services. And so with that, we need more qualified psychiatrists, right? People with treatment experience serving those with IDD. There is the belief that that many people feel they are unable to serve people with IDD, and we know that with some training and exposure to individuals with intellectual and developmental disabilities, we can start to shift this narrative. We also know that it's important to provide more access. So many respondents said that they reported no access or no knowledge of psychiatric services from qualified psychiatrists. And so it's also about educating folks with the information from their local authority to ensure that they know where to go and how to access mental health services for both themselves and their family members. The third focus is on the IDD Service System. Practitioners recognize that there are gaps in their own expertise and training. 97% of IDD providers reported a need for additional IDD and mental health focused training. So we know that we need to improve collaboration between IDD and mental health service providers. We need enhanced training on the signs and symptoms of mental health conditions in people with IDD, because mental health symptoms can look different for an individual with an intellectual or developmental diagnosis. And that's important that we're exposing mental health professionals to what that might look like. Additionally, there's the need for education and system navigation support for families. As I mentioned earlier, families tend to be heavily involved in providing the care for their loved one who may have an IDD diagnosis. And so we heard over and over again that many families don't know where to go or who to turn to or where to find resources. And then finally, the fourth focus is on community education. It's no surprise that a sense of community is a strong protective factor against mental health crises. So when a person feels valued, when they're engaged with their community, it fosters a sense of inclusion and positive engagement and overall improved quality of life. Community members, including school resource officers, educators, and medical professionals, as well as religious leaders, are all folks that we would like to engage more with in order to create the stronger sense of improved quality of life. So this can look like a lot, but of course it includes the need to fund existing services such as the wait list, so we can help prevent Texans with IDD from getting to the point of experiencing a mental health crisis. It also looks like people with IDD accessing inclusive education and meaningful employment. All of these help build a strong sense of inclusion, positive engagement, and again, ultimately an improved quality of life. So there are so many different things that we can do. We're really excited to share this report with you all and the findings so we can work towards improving access to mental health supports for individuals with intellectual and developmental disabilities, and ultimately keep folks with IDD out of the criminal justice system. Thank you.
All right, good morning. My name is Kelly, and I work for MHMR in Tarrant County, and I currently oversee the 3 programs that have been mentioned, so the OBI program, the START program, as well as our criminal crisis intervention specialist, the CIS role. So I'm going to talk a little bit about START. Alex mentioned it, and it is a national model that is being implemented in Texas, and we've had it in Tarrant County since 2013. And the START model is systemic therapeutic assessment, resources, and treatment. And we are a biopsychosocial model, so we really look at the whole person instead of just what their diagnoses are. So biologically, psychologically, and socially, what could be impacting the individual's acuity for crisis. And we are very trauma-informed, positive psychology, and strengths-based. So we implement that currently in Tarrant County and have been doing so for many years. When the OBI grant came about, we were one of the 5 pilots counties for the pilot program, and so we implement that under the START model. So our OBI CCCMs are trained in the START program, and they provide those same supports that the START program would also provide in addition to what OBI. The other thing that we do in Tarrant County that fits really perfectly into START, CIS, and the OBI grant funding is we train local law enforcement officers on how to interact with individuals with IDD and autism, and also what mental health can look like in individuals with IDD and autism. And we currently train 3 of the largest police departments in that area, as well as at a local college when they have in-services and new recruit classes come through there. We also provide, so you'd be surprised how many parents get a diagnosis and then get handed a piece of paper with that diagnosis description and then don't really have the ability to understand what that diagnosis means. And it can be as common as autism. Some parents don't even know what it means for their child to have autism. And so we also provide very in-depth trainings to families, providers, schools, and local law enforcement officers on specific diagnoses as well. We hold monthly trainings, which are called clinical education team trainings. Once a month, they're virtual and in person, and we choose a topic for discussion for that training, and we invite providers in our local catchment area as well as send them out to local other counties as well. We're hoping that our interaction and involvement in those trainings reduces interaction or unnecessary interaction between police officers and also unnecessary hospitalizations. We dual dispatch with our local police departments, and so if an officer were to call we also have a 24-hour crisis line, and we give it out to our families as well as local authorities as well as officers. And if they call us, we will dual dispatch with them on the spot and assist them with the interaction between them and the individual that might have an IDD diagnosis. We are not a very big program. I think we have about 7 coordinators on the ground right now, and we serve all of Tarrant County. In my trainings with local law enforcement, I realized that the college that we currently train at is all surrounding counties, and so, but we only are in Tarrant, and so the need is much bigger than just Tarrant County. And so we dual dispatch with them. We also work with our local law liaison department, which is also part of Tarrant County's system. And they go out on mental health calls when they suspect an individual has IDD or autism. They call us and we go out either with them or the next day with our CIS role. We have, as Haley mentioned, crisis respite in Tarrant County, and it is operated under the START model, which is that biopsychosocial model. We do therapeutic supports. We have 4 beds for all of Tarrant County, and the need exceeds that immensely. And we only serve 18 and older, so you have to be a legal adult, or not a legal adult, but you have to be adult in the state of Texas in order to receive our crisis respite at this time. And the need for children in crisis respite is also extremely high. we do in-person responses for the families that are in, or the providers of individuals that are in our programs. So if they call our support line, we try to identify the need for us to come out as opposed to law enforcement officers. So if it reaches this point, please call us. We'll go out and try to de-escalate the situation, so that way it doesn't pull an officer off the street, because most times those 911 calls could probably be resolved by just de-escalation by our team. So we also, at Tarrant County, try to get into the local hospitals. We currently train one of the children's hospitals and work very closely with liaison at our county hospital to identify individuals in our system, so we can have interaction with them upon their discharge or help assist with the discharge planning. In Tarrant County, we have a very robust system of support for these individuals, and we still have individuals that fall through the cracks. We have individuals that don't have the certain diagnoses, certain IQ to get certain services. As Alex mentioned, there's this huge misguidance that individuals with IDD cannot benefit from trauma services, and they most definitely can and should, because they are a very traumatized population. Yeah, so that pretty much wraps up our role in Tarrant County. Our OBI program that we implemented over the last year has been very successful. The additional supports that program was able to provide to us has led to some very good outcomes. We were working with a young lady who was being very assaultive, and 911 was having to be called very, very frequently, almost daily, and several times a day. And when our program was able to get involved, and knock on wood, somebody, since July, we have had 0 hospitalizations and 0 911 calls. And so it's very impactful when we can implement it and get it done. We also are able to guide law enforcement officers on the scene. We had a law enforcement officer call us. This guy is suicidal. He's currently at school, but he has autism, so I don't want to take him to the hospital. And we were able to guide him through that. Just because he has autism does not mean he cannot also have suicidal ideation. And so we were able to get that young man the help that he desperately needed. And so with the implementation of all of these programs, we are able to service Tarrant County, and it expanded and throughout the state of Texas would be greatly beneficial.
Okay, good morning. My name is Whitney Sherman. I'm a licensed behavior analyst, and I'm at the Andrews Center in Tyler, Texas. So we serve Smith County and 4 counties surrounding Smith County. I oversee our autism and behavior intervention programs, and those programs started about 12 years ago, mostly just serving young children with autism, kind of providing early intervention services to them. And over the last 12 years, our programs have grown to serving children with autism primarily still, but up to the age of 16 right now through HHSC's Children's Autism Program. And then we've expanded to providing behavior support services through the Medicaid waiver programs. We are a TEA-approved private, non-public day school. So we have students placed with us that have not been successful in their school programs. And so after working with mostly children, but also moving towards adults with autism and IDD, and implementing behavior intervention services with them over several years, we identified that our IDD crisis program that Haley and Kelly have both been talking about, they were coming in contact with lots of individuals with autism who were struggling behaviorally, and that was really the root of their crisis, was a behavioral issue. So Rachel, our crisis intervention specialist, she's amazing, she's here. 2 years ago, we decided, we kind of waved our hands and said, well, we would love to try taking the program, utilizing behavior intervention services through this crisis intervention support program, because we had high hopes of solving the crisis, right? There's a crisis, we can fix it. And so that hasn't necessarily happened over the last 2 years, but my goal today is to provide you a little bit more information about what we're doing in a rural area of Texas with just crisis intervention funds through HHSC. It's general revenue funded, and hopefully give you an idea of kind of what just additional things that are available in all areas of Texas, and hopefully you see it as a resource to you and the people that you're working with. So the IDD Crisis Program, again, it's funded through general revenue, and luckily the criteria to qualify for the program is very flexible. Anyone in the state of Texas who has an IDD diagnosis and is at risk of or has a perceived risk of harming themselves or others qualifies for the program. So that's any age, and there's not necessarily a level of severity of IDD that is required. And it also, somebody with a dual diagnosis of mental health concerns and an IDD diagnosis does qualify. So I think we've all been kind of harping on the issue of, there is a significant issue with people with dual diagnoses, this IDD and mental health concerns. And so luckily they do qualify for the IDD crisis program. And because of this really flexible entry criteria, we've been able to help a lot of families. It really allows us to connect with a lot of individuals. So as far as referral sources, we have been working over the last couple of years to just make connections with anyone and everyone who may come in contact with an individual with IDD who is in crisis. And so we work really closely with our, at the Andrews Center, our service coordinators, our mental health caseworkers, our MCOT team. All those individuals kind of have us on speed dial. They're able to call us quickly if they come in contact with one of their clients or a family calls for intake, and they are identified as potentially being in a crisis situation. We tell them to send them our way. We also attend community resource coordination groups, known as the CRCG, and in Smith County, we attend the monthly CRCG. It's held at the Juvenile Detention Center, and this is a really neat opportunity for kind of community resources to come together, and people are able to present cases of children who, whether they have IDD or not, who have potentially come in contact with the criminal justice system, or who their family is just struggling. They're having behavioral issues, they're struggling at school, they maybe have just moved here and they're not connected with any resources. And so we attend those pretty religiously and try to either connect the families with other resources if they don't qualify for our programs, or connect with them if they do qualify for our programs. And so that's a great referral source. Haley mentioned TLETs, and so we follow through with any matches in the TLET system. Any individuals who have been arrested that have received IDD services at the Andrews Center, we connect with them, make sure that they're moved out of general populations, we connect with their families and make sure that there are supports in place if they are released from the jail system, so that hopefully we don't run into a situation of them being arrested again. The mental health crisis line, we've worked with our local mental health crisis line, whereas Kelly was talking about their program has their own mental health crisis, or their own kind of 24-hour crisis line. We've worked with our mental health crisis line to develop kind of a flag system where they're able to flag individuals who have an IDD diagnosis, and we check those logs. If we see someone who's been flagged as an individual with IDD, we're able to connect with that family and just reach out to them and say, are there some services that we can offer to you or help you get that could potentially ameliorate this crisis? Our local HCS providers and group homes, the group homes in our area are familiar with our program. They're able to call us if they have a consumer that's living at one of their homes that's having a crisis situation. Our local emergency department and the psychiatry program, UT, has a great new psychiatric residency program. And so Rachel and I are actually going next week to speak to their residents and kind of prepare them for what, again, serving an individual with IDD and mental health concerns might look like, and just tell them about the services that we provide so that they know what resources are available. And then there's this local special needs pediatric clinic that we've connected with. They provide respite through a grant, and then they also pediatric pediatric services to children with special needs, and we've connected with them as a referral source. So our goal really is just to connect with anyone who might need our services. And so what do we do? What does it look like whenever we get called out, we get a referral? The first order of business really is an assessment. And pre-COVID, we did all of our assessments face-to-face, and telehealth, the immersion of telehealth has really been beneficial. We're able to kind of get those done quicker if needed, but our goal is to get those assessments done quickly. And we've taken really a behavior analytic approach to doing these assessments and looking at what is the reason behind the behavior issues that we're seeing, and really digging into, is this a communication issue? Are we working with an individual that is not able to use speech as communication and doesn't have another way to communicate? Is this a psychiatric issue? Do we need to have this person looked at by a psychiatrist to see if there is a mental health issue that's gone undiagnosed? Is there a medical issue going on? Do we have a UTI? Do we have constipation? There are so many, medical issues. Do we need to refer to just your PCP or a PCP? Maybe you haven't been seen in years. Are there other things? Do you just really have a history of reinforcement? Your behavior has kind of slowly been increasing because you've been living at home. Maybe COVID happened and you've been home for 18 months and haven't been in school. So our goal really is to dig into what's really the root of the issue here, and how can we tackle that issue, as opposed to just putting a Band-Aid on the crisis and then seeing you again in a couple of months. So once we've completed our assessment, we develop a plan, and the plan has kind of three parts: intervention, respite, and resources. And so that intervention piece, Alex was talking about how important it is to have individuals who are highly skilled, but also providing training to the families and the caregivers who are working with and trying to raise these individuals day in and day out. So we're utilizing evidence-based strategies and interventions that are based in the principles of behavior analysis, and not just developing some intervention recommendations, but providing direct hands-on training to the parents and the caregivers, maybe in the group home, the teachers at the schools, the grandparents who are raising their grandchild, providing that training hands-on directly to them. They're able to call us and say, hey, I'm trying this and it's not working, and work through that with them, make adjustments when needed. We utilize and have been trained in a curriculum called Safety Care. It's a kind of a crisis intervention program that was developed by behavior analysts that's specifically designed for people with IDD. And so we're able to utilize some of that to teach families some really great tips and tricks to use to prevent these behavioral crises from occurring. Some other examples of kind of the intervention strategies that we've used: we had a young lady who ran from her home multiple times. This was like a every week event, and we were able to work with her family and the local police department and fire department. They were typically called whenever she left her home. We developed kind of a community crisis plan that we laminated and put in her mom's car, so that if she had to call the police or call the fire department or the ambulance, she was able to hand that to them, and they had some kind of direction on how to interact with this young lady, because the typical interactions that may involve hands-on interactions or things like that would exacerbate this situation significantly. And so we were hoping, even if we can't be there by the time the police are there, you can hand this to them, and it will give them some kind of direction on how to interact with her. We had a young man who was arrested for making a terroristic threat at school, and we were, through some assessment and working with him and his family, we were able to identify that he had some significant expressive communication and social skills delays that resulted in him not being able to express his unhappiness, except for to use some quotes that he had heard from a movie, which were misperceived and taken as a terroristic threat, and then he was arrested. And so we were able to work with the attorney that was working on his case, kind of develop a plan for how we can teach him some more appropriate ways to say, I don't want to do this, as opposed to making threats that could result in arrest again. So as a side kind of to that intervention piece, Our goal is, we're crisis, and this is short term. We only have kind of this little blip of time with you, and, really research with individuals with IDD, and especially those with dual diagnoses, is that this is a marathon. This is not a sprint, and especially if we're escalated to a point where we're engaging in severe aggressive behaviors towards others or towards ourselves, we need long-term resources, whether this be in home or in a residential setting. And so that's another one of our goals, is just to connect these individuals and these families to resources that will help sustain them and potentially prevent them from coming back into crisis. So that can include service coordination, potentially getting them set up if they're not on waiver lists for behavior intervention or for residential support, getting them connected with those services, connecting them with counseling. And Alex and Kelly were talking about how these consumers, they benefit from counseling. So we've worked to kind of connect with counselors who are comfortable with and have experience with people with IDD, so that we can send the consumers that we come in contact with directly to them as a referral, connecting them with a psychiatrist if they're not already connected with a psychiatrist, or maybe working with their psychiatrist on kind of building a team for them. Respite services, even there's crisis respite, but then even long-term respite services to give parents a break, more regularly. And then educational support and advocacy, working with their families through the special education system, helping develop IEPs and behavior intervention plans for the school that are going to be effective and maybe prevent some of these situations from happening, connecting them with advocates that can help them through that process as well. And then we follow up with them. Our goal is to follow up with them for 6 months. We hope that if we follow up with them regularly and kind of keep all of the pieces together and their teams working together, that after 6 months we're able to kind of discharge them, and we hope that they're doing great and they're on their way. But sometimes we have people come back into crisis, and that's okay, and we kind of reassess the situation. And so Alex talked a lot about barriers, and I think we're familiar, with the barriers. I don't want to harp on it, but I think there are some good things that are coming up. They're talking about waivers, but then also the state of Texas is, as of February, children with autism will be able to access behavior intervention services through their Medicaid plans up until the age of 20, which is really amazing. And I'm biased, I'm a behavior analyst, but I really feel like that kind of starting at the ground level and working with these children to teach them the skills that they need will hopefully prevent us from having to put so many funds towards crisis intervention and the criminal justice system. And I think we're doing a great job of kind of starting at the beginning and kind of fixing the root of the problem. So that's what I have. I think we have time. What time is it? It's 11. Maybe no questions?
We have 5 minutes. I believe we have 5 minutes for questions. Does anyone have any questions?
So a lot of times with the youth, the parent has been the advocate prior to having any type of dealing with the child in the criminal justice system. And a lot of times the resources are funneled at the intersection of the criminal justice system. But instead of the idea of coming in to help at that intercept, wouldn't it be, does your agency try to intercept prior to those behavioral issues, getting to a point where they would have to be secluded?
Sure.
Just like normal setting?
Yeah, no, that's a great question. And so our other programs, our behavior intervention and autism programs, that's kind of the goal there, is to, we're providing you, you're not in crisis yet. We're providing you the services and supports you need, and that's where I was talking about Medicaid being able to provide behavior intervention services up to age 20. That is kind of the prevention piece, I think, is we've providing through the school systems, through psychiatric care, through counseling, through behavior intervention, providing all of those services before we even get to crisis is really the answer, right? Oftentimes when we get called out for crisis, so many times these kids or adults have not received these services up until now. And so really the answer is yes, prevention through lots of services and intervention early on and providing those until they're really not needed anymore. But yeah, you're right. It makes a lot more sense to provide it on the front end than to just be a Band-Aid. And that's not helpful, but it's what's available.
A lot of times too, through the SHARS, the school acts as a service provider and they get refunded from the state.
Yes.
Thank you. A lot of times, as well through SHARS, they act as a service provider, the schools do, but the parents are kind of, there's no intercept at the school setting to assist the parents.
Right.
Before it even gets escalated to that point. So anyway,
Yeah.
I
I would
appreciate
just
that.
like to add something to that. Sometimes there's some confusion that because you're receiving services in the school, parents don't understand that they can also be receiving outside services as well. And so we try to advocate on the front end, get into services early, get their names on the lists early before they get to puberty and bigger and stronger, because that's usually when the crises really start to happen, is when they're between like the ages of 10 and 16. And a lot of parents don't know that they can call and request services prior to them graduating from school.
That is true. I have a question. Do any of y'all have like a person that would go to the school to help the parents? Y'all do? That's
Our whole
good.
team is trained in advocacy for the school. We also connect them with advocates in the state of Texas. We also have a role at our agency as a family support advocate when we don't have the time to commit to certain cases. But we also dispatch to the school when there are crises.
I think it's also important to note that not every child receives a diagnosis early on. It's not uncommon that people will go their entire lives and not know that they have any sort of disability until they enter the criminal justice system as adults. And then many lawyers struggle to then try and figure out, how do we get this person assessed and show that there is a disability here, which is why the event may have occurred. And so if these adults are not receiving services early on, if they're not receiving special education, there may be stigma associated with it from their culture or their family, then, problems occur later on in life. So not every child is getting the necessary resources from a very young age.
Thank you. I believe we can take one more question, and then we have to go ahead and go on to the next panel.
Hello, I'm a LVN, and I was wondering, will these programs lend help to nurses that I work in home health with special needs kids, pediatrics, and I have gotten beaten up on. I've dealt with behaviors. The parents don't know what to do. My company doesn't know what to do. Will there be additional support for the nurses that are working in the homes with these kids and the parents and the schools and the doctors to help this individual when there's a crisis? Because I've been there many a times trying to figure out what to do, what's the next step. They get referred to a PCP. The PCP kind of puts them on medication, and then we just go from there. And so I'm just wondering, can we partner up with home health companies to get training for the nurses to help deal with the patient, deal with our kids, to help them?
Yes. Let's do. I think one of the key things that would be a good partnership is probably, I talked about those transition support teams that are those clinical group of folks that are at each, there's 8 of them around the state that cover all 254 counties. Their primary goal is to provide education, training, and technical assistance to any service provider that supports people with IDD. And so, yeah, let's connect offline and figure out who your transition support team is in your area and see if we can't get you guys connected for some training and technical assistance. Sounds great. Thank you.
So as much as I want to continue to have this discussion, I think a lot of the information I can attest to, as well as being a juvenile judge and knowing how important it is for prevention and not being reactive. It is extremely important. And so thank you to each and every one of you for sharing those resources and this very important information. Of course, at break or at one of the breaks, you can go ahead and ask any additional questions that you may have to our panelists. Thank you. A round of applause for them again.